learn from you and hopefully teach something as well. So if we're talking about lateral surgeries, those are my disclosures. I consult for a few companies. I sit in the advisory board of others, but none of those are related to what I'm presenting today. So in 2024, if we are searching the word gold standard or the benchmark, it's basically something that we can compare something to. And I hate it in 2024 that we still consider TLIF as the gold standard surgery, because TLIF is a terrible, terrible surgery. And here's my biggest disclosure: I'm a TLIF hater. So if you look at TLIF, it's a lot of destructive surgery. You're working between the exiting and the traversing nerve root, and you're trying to get that cage in there. You're not having enough bony contact, and you're not having enough surface area for fusion. And don't take it from me, take it from the guys from Jefferson University by Alex Vaccaro. We consider those guys gods on earth in spine surgery. You can see here that they reviewed 120 patients with single level TLIF, and 46% of those developed complications. 11% of those developed postoperative radiculitis, and almost 10% went through another operation as a revision for that TLIF surgery. So TLIF is not an easy surgery. It's actually a very morbid surgery. So when I think about TLIF versus lateral approaches, I always ask myself a couple of questions. Do I trust in direct decompression? And I think that's the most important question. Is the anatomy favorable? Can I go lateral for this patient? Do I need alignment of correction? Is it a deformity case? And should I include an L5S1 level in this surgery? So the first time you do this, it's a leap of faith. You don't really know if it's gonna work. Are you gonna end up getting a direct decompression for the patient because it didn't work in the first place? But in 2024, you have enough evidence that says that lateral approaches do work very well in decompressing those patients. And there are a lot of papers out there. I'm not gonna bore you with those, but I'm gonna just show you one here that shows that OLIF actually, or lateral approaches, have a much better fusion rate than TLIFs as well. And even in those cases with central stenosis, we do know now that direct lateral approaches or anterior to psoas approaches do work very well in decompressing central stenosis as well. So when we are talking about prone lateral versus lateral decubitus and then flipping the patient, or a two-approach lateral as we call it nowadays. So people who are doing prone lateral will tell you that there are a lot of advantages of this. It's a position that we are already aware of. Every spine surgeon is aware of the prone position. You can place your screws at the same time. If you need to do some direct decompression, you can probably go in and decompress the patient at the same time. And then they'll probably tell you that you can get some better lordosis placing that paper on the Jackson table by getting an extra lordosis at the lumbar area. But what they don't tell you is the limitations and the disadvantages that you have of the prone lateral surgery. And just to mention a few here, if we're talking about lateral approaches, we're talking about the transpsoas and the anterior to psoas approach. And for me, one of the biggest limitations is that you cannot do an anterior to psoas approach in the prone lateral. And that's for a very obvious reason. If you take a look over there, that's another patient here that I usually call a Dubai medium. You can see here that in order for you to do an ATP, you have to be under that patient down there. So it's not doable in a prone position by any means. So let's take a look here at the difference between both surgeries. So if you're doing a direct lateral approach, you're obviously going through the psoas, you're doing this middle third discectomy, and then you're trying to push your implant inside. The problem is you're not approaching the posterior third or the anterior third of the disc. So there is a very good chance that when you're pushing that cage in, you can push that posterior part of the disc into the canal. And we have seen that over and over again with the direct lateral surgery, which is the only approach that you can see in patients who are doing prone lateral. But let's take a look at the ATP. You're landing anterior to the psoas. You're doing the majority of the discectomy, reaching all the way even to the contralateral nerve root. And then at that point, you're creating a lot of negative pressure inside the disc space. So whatever disc material is left in there is actually pushed inside the disc space instead of being pushed outside the disc space. What about the lumbar plexus? It's a topic that has been raised for a very long time. And we always talk about doing those surgeries under neuromonitoring, and it's very important to do this. But the truth is, we know nowadays that it's not as a result of injury of the main nerves. It's actually as a result of injury of the perforators, as we got to know from the anatomic study by Danny Galb. And even for the genitofemoral nerve that results in retrograde ejaculation, it runs in the anterior third of the psoas. So again, direct lateral going through the psoas has a lot of morbidity and a lot of risk of injury of the nerves. And again, we know very well from the results of Federico Gerardi in his study that almost 10% of patients ended up with a permanent sensory deficit, and almost 3% of them ended up with a permanent motor deficit. So again, direct lateral can be a very, very morbid surgery. Now let's talk about biomechanics, because they are not the same surgery as well. Let's take a look at the direct lateral. So you did your pathetic middle stair discectomy, you push the cage in, you push the trials. Now you're not happy with the size, you pushed a bigger trial in, you started to get some correction of the lordosis over there, but then you have that fulcrum in the front of the ALL, as you can see over here. So you get greedy at this point, right? You want to get more lordosis, you want to get a bigger implant in, so you start pushing more cages in, but at this point you cannot get more lordosis because the ALL is a fulcrum at the front. Instead, you're stretching the PLL and the posterior ligamentous complex. And that's why down the road, 6 weeks down the road, when you see those patients, you probably end up with some sort of subsidence happening because you have all of those forces pushing against the cage. But let's look again for ATP surgery or anterior to psoas approach, which is totally different in this case. So again, the same steps, you go to that point, you're stretching the ALL, but now because you're anterior to psoas, you have a chance to take that ALL completely out. And then when you do that, that's when you can use those hyperlordotic cages that are offered to you by the companies, the 12 and the 18 degrees. So, and that's what allows you to achieve what I've done over here. Instead of having this very flat lumbar spine, you can achieve that much of a lumbar lordosis. We always talked about ALF being the surgery that achieves the maximum lordosis. You can actually do that from a lateral approach by just releasing the ALL. And that makes a lot of difference. And let me show you some cases here. This is a 67 years old male patient, history of L3 to 5 endoscopic decompression 1 year ago. Obviously, he didn't improve after surgery, and he cannot walk more than 200 meters and cannot stand more than 10 minutes. This is his x-rays. You can see that he has degenerative scoli in the lumbar spine. He has a lateral recess stenosis on the MRI. And you can see here, by just taking that ALL out, you can create significant amount of lumbar lordosis at every single level between L2 to L5. The other question that I asked myself that I said earlier, what about the L5-S1 level? So if I'm doing prone lateral, I can achieve L2 to L5 if I can achieve 4-5, because sometimes you have a very high iliac crest that covers 4-5 already. So if I'm doing L5-S1 from an anterior approach, I need to flip that patient again to a supine position to achieve that anterior, and then flip him prone again to do the posterior again. So this is not the case if you are doing a lateral decubitus lateral, because once again you can achieve that L5-S1 from the side. This is a case here. She is 66 years old, female, not a male patient, who had a previous history of L4-5 fusion secondary to spondy. And you can see here that he has significant disruption of his sagittal balance. His SVA is somewhere around 13 centimeters to the front, and he has complete loss of his upper part of the lumbar lordosis, and he's falling into kyphosis a lot in the front. So here is what we did for him through a single approach as well. So we went ahead, we did an L5-S1 from a lateral approach by putting the patient in a lateral decubitus position, and we fired 3 lateral cages from L1 down to L4. And that managed to correct his lordosis significantly. That managed to correct his sagittal balance without the need to do any osteotomies. Now, once again, that's something that you cannot do in a prone lateral by any means. That's only in a lateral decubitus position. And I leave you with this case. This is a 65 years old female patient, long-standing history of lower back pain, radiculopathy. She has been suffering over the years, received several decompressions, several transforaminal epidural steroid injections, no improvement. That was her x-rays. And you can see here that she has a terrible degenerative scoli in the lumbar spine. Her sagittal balance is all over the place. Those are her long-standing films. She's all over the place. This is her MRI, and I don't have the axial cuts here, but you can imagine that she has that lateral recess stenosis happening at every single level, and at the level of 4-5 and 5-1, she has severe central stenosis as well. So once again, if I put this patient in a prone position, I'll probably be able to get 2 or 3 levels from the side, but then I'll probably have to end up, I'm not able to release the ALL. I'll probably have to do some posterior osteotomies as well in order to correct her and get her in position. But this is a patient that we decided to take her from the side as well, so we approached her through an ATP approach, and we managed to get all the way down to L5-S1 and all the way up to T12-L1. So you cannot get to 5-1 and you cannot get to T12-L1 by doing a prone lateral. That's only done in a lateral decubitus position. So bottom line, the problem is lateral surgeries are here to stay. You can achieve a lot of pathologies, you can treat a lot of pathologies by doing lateral surgeries. We have all the evidence nowadays that this corrects deformity, that you can treat deformity, you can treat tumor surgeries, you can do a lot of things from lateral approaches. And if you are planning to, if you want to be a more versatile surgeon, if you want to achieve the L5-S1 level and above the L2 level, then prone lateral is not the way to go. It's the direct lateral decubitus approach is the way to go. And always try to be ATP as much as you can instead of going through that psoas. Thank you very much.